Hello, everyone. Welcome to today's live broadcast, MRSA Screening Program at a Community Healthcare System. I am Judy O'Rourke of LabRoots, and I'll be your moderator for today's event. Today's webcast is presented by LabRoots.com, the leading social media site for science professionals, and sponsored by Roche Diagnostics. As a global leader in healthcare, Roche Diagnostics offers a broad portfolio of tools that help healthcare providers in the early detection, prevention, diagnosis, and treatment of diseases. In molecular diagnostics, the company is driven by a vision of working with laboratories like yours to improve the medical value you offer in microbiology, infectious diseases, oncology, and genomics. Roche Diagnostics continues to meet unmet needs through its investment in research, innovation, and scientific excellence, with the goal of supporting your important role in improving patients' lives. Before we start, there are a few instructions. We want to hear from you during this interactive broadcast, so please ask questions or leave us a comment. Answers are welcome too. You can do this by hitting the green Q&A button at the lower left of the presentation window and typing in your comments and questions. We'll try to get to as many as we can, and we'll follow up if we don't have time today. Want a better look? You can enlarge the slide window by clicking on the screen icon in the lower right-hand corner of the slide window. If you can't hear or see this presentation properly, let us know by clicking on the support button on the top right or use the Q&A button. We'll make sure we try to resolve any issues. Now let's get right to today's presenter. We are proud to welcome Dr. Rodney Arcenas, clinical scientist in microbiology, immunology, and molecular at Pathology Consultants of South Broward, LLP, within Memorial Healthcare System. Dr. Arcenas earned a BS with honors in microbiology from the University of Florida in the spring of 1997. He continued his microbiology training at the University of South Florida College of Medicine, graduating in 2002 with an MS and PhD in medical microbiology and immunology. Dr. Arcenas was then accepted into the Clinical Microbiology Fellowship Program at the Mayo Clinic in Rochester, Minnesota. After completing his fellowship, he was hired in 2004 at Lab 1 Incorporated in Lenexa, Kansas, to be the scientific director of microbiology and immunology. He left Lab 1 in 2006 to join the Pathology Consultants of South Broward, PCSB, as their clinical scientist for microbiology and molecular testing, and has been there since. In his time with PCSB, Dr. Arcenas has helped to start the Molecular Infectious Disease Testing Service, which has grown from a day shift operation with 2 medical technologists, 8 hours Monday through Friday, to having 5 full-time and 3 part-time medical technologists with 24-hour shifts Monday through Friday and an abbreviated 1.5 shifts on weekends. He has also helped spearhead the implementation of a successful MRSA active surveillance program that started in 2008. Dr. Arcenas is board certified as a diplomate of the American Board of Medical Microbiology. I will now turn it over to Dr. Arcenas for his presentation.
Well, thank you for the introduction, and thank you everyone for joining us today. So, as mentioned, I will be discussing MRSA screening program, and in particular our environment and our setting, and kind of go over the drivers and implementation and planning and development and some of the outcome metrics related to our development and implementation of a MRSA screening program. So very briefly, some of the objectives we'll be discussing today is, again, understanding what kind of drove us to developing an active surveillance program, also discuss kind of the planning, implementation within a multi-hospital community healthcare system, and then lastly to show some of the downstream successes of our MRSA screening program. So just a very brief background about our environment down here. We're located in Broward County, which you can see here in South Florida, the county colored in red, and we're actually in the lower half of that county. And we're a total of 6 hospitals, one of which is a children's hospital. In total, we have about 2,104 beds, and it's the 3rd largest public healthcare system in the United States. Now, sort of drilling down into that South Broward County, what we have here going from left to right, or west to east, we have our hospitals, Miramar, located here in the west, and actually about several miles to the west of that is the Everglades. And so moving east, we have Memorial Hospital West here, Pembroke, and then our flagship hospital, Memorial Regional Hospital, that has on the same campus our Children's Hospital, the Joe DiMaggio Children's Hospital. And then lastly, down here is our Memorial Regional Hospital South, and that's where our molecular lab is located. And then actually, if you go several miles east, it's you're at the beach. So just kind of give you an overview of our kind of physical environment and where our molecular lab is centralized. Obviously, specimens need to get delivered in a timely manner, and so it's always a challenge in South Florida traffic for couriers to get specimens over here from our Miramar Hospital West and then headed to our molecular laboratory. So yeah, it is quite a challenge, and as the crow flies, I guess you can this from Miramar Hospital over to Regional South. It's about 12, 14 miles, but obviously the traffic will feel like much longer. So getting into sort of the meat of the talk, when implementing any kind of infection control program, it's good to understand the scope of the problem you're trying to address. And so obviously for us today, we're going to be discussing MRSA prevalence, and I wanted to sort of start out at sort of a United States national level, kind of drill down to Florida level, and then talk about our specific environment here. So, Jarvis et al., and I have reference articles down here at the bottom, the authors performed kind of a snapshot study back in 2006 and then in 2010, and looking at not only infection rate, but interestingly, they also looked at colonization rate. And these were questionnaires that were submitted to hospitals within the APIC membership, the Association for Professionals in Infection Control. And so they took snapshots at these two different times. And I have to apologize that the data here for this 2006, 2010 should be reversed. So in 2006, it should be 46.3 colonization rate. In 2010, it actually showed an increase in colonization rate at 66.4. So keeping that in mind, there was an increase in colonization rate, and one could argue that it's because there's an increase in the number of institutions performing MRSA screening compared to the prior year. So that's kind of interesting to show that, yes, we're detecting more colonization, but is that because now more institutions are screening for MRSA? And then if you look at the infection rate in here, you can see where it's actually a decline in the MRSA infection rate. Again, one could infer that healthcare workers, healthcare institutions are just more aware of MRSA and again, implementing not only screening programs, but then potentially implementing decolonization regimens for those that are MRSA colonized. And then this last column, if you look at the percent detected with, or at least less than 48 hours of hospital admission, sort of gives an indication that most patients are already presenting to the hospital colonized with MRSA. And this sort of coincides with the incidence of, or increasing incidence of, community-acquired MRSA. And then another set of data to look at, and this is from the CDC, and this is actually from 2013 data that was published just earlier this year in January. CDC put out a National State Healthcare Associated Infections Progress Report, and so it's another way of looking at the scope of MRSA. And so this slide can be is kind of busy, so I'll try and go through it and kind of give the explanations. You see here CDC collated this data. Basically, number of U.S. hospitals throughout the U.S. submitted data based on infection rates and looking at central line associated bloodstream infections, catheter-associated UTIs, surgical site infections, and then, of course, the thing to focus here is MRSA bacteremia. And you can see with the number of hospitals reporting, and they report the data as an as an SIR, as you see here in this last column. And SIR stands for Standardized Infection Ratio. So it's a way to normalize the data so that you can truly compare from one year to another, one state to another, to get an idea of where you stand. And the lower the SIR, the better you are. So generally speaking, as a nation, when you look at the 2013 SIR is 0.92, and you can see there's a national baseline that was established in 2011. So we're actually lower this year, which is indicative of overall efforts towards being aware of hospital-acquired infections and MRSA bacteremias in general. And then compared to the prior year, 2012 to 2013, again a 5% decrease in the SIR. However, when you drill down to the state of Florida, obviously there's going to be kind of more specific numbers. And when you look at and focus on bacteremia, you can see here Florida's not doing the best job. But again, it's sort of indicated by the number of hospitals that submit data. So it's, there's a caveat to the data being presented here. But it gives us an indicator of, generally speaking, how well your particular state is doing. And this report has all the 50 states in this document. So it's kind of a good idea to see how you compare to others and see where and how the state is doing with regards to hospital-acquired infections. And then another way to look at it is to look at the impact on the sort of estimated annual death rate. And this is also CDC data looking at the antibiotic-resistant threats in 2013. As you can see, going down the list, the carbapenem-resistant Enterobacteriaceae, multi-drug-resistant Acinetobacter, fluconazole-resistant Candida, the ESBLs, VREs, multi-drug-resistant Pseudomonas, as well as drug-resistant MTB, C. diff, they hover around 5–6% annual death rate. And then when you look at Methicillin Resistant Staph aureus, you can see here the estimated annual death rate approaching 14%. So again, MRSA being a larger percentage of contributing to the estimated annual death rate. So again, another indication of trying to understand the scope of MRSA. And then sort of drilling down to our institution, this is antibiogram data. So this is MRSA that's been isolated as a result of a clinical infection, not for screening. So just to give you an idea, the majority of Staph aureus that we isolate in our microbiology laboratory is MRSA. So again, just giving an indication of kind of the scope of the problem. And I have a later slide that actually shows a point prevalence study we did, and I'll discuss that more into the planning stages and development stages that we did. But again, it's sort of interesting data just to understand kind of the national scope, and then as you drill down to your specific environment. Now, one of the things that sort of worked its way into kind of institutional medical practices is legislation, and these aren't, and generally speaking, these aren't necessarily medically based, but again, something that in reality we have to deal with. And so this is a number of states have actually implemented legislation and enacted laws saying that healthcare institutions need to develop or establish a MRSA screening program. And you can see here, this is data from, actually it's last updated, you can see down at the bottom, 2011. So the states in blue are the ones that have enacted and implemented MRSA laws, MRSA screening laws, so that they're required to undergo or implement a MRSA screening program. The state of Florida, at least since back in 2011 and through today, they've at least discussed making it a legislation, but I don't think anything has come to fruition yet. But our healthcare institution does voluntarily report our surgical site infections and other hospital-acquired infections, and so it's part of a initiative from the state to sort of track these and document these. So again, legislation working its way. APIC and SHEA, APIC, the Association of Professional Infection Control, and SHEA, which is the Society for Healthcare Epidemiology of America, put out a statement in 2007 basically stating, and I have here a quote from the document, position statement, saying that they do not support legislation to mandate use of active surveillance for MRSA, VRE, or any other antimicrobial resistant pathogen. So again, it's up to the institution, and each institution is going to be different, have a different environment, so it's hard to put sort of a blanket legislation or in practice to really apply to all institutions, because some institutions may not have a MRSA problem or other infectious disease related problem, and some institutions might. It just really depends, and that's something that if you're seriously considering implementing some sort of infection control program, that it's important, again, to understand the scope of the problem within your setting. So why screen for MRSA? And that's the kind of the big question of, why to even go forward with this. And there's a number of literature articles, editorials suggesting the benefits of MRSA screening, and then there's on the sort of the opposite end, there's articles and editorials suggesting a lack of benefit for MRSA screening. And one of the problems in when you read these literature articles and editorials is that each institution is going to be different. The patient population within each institution is going to be different, and then also the method of how you're screening, whether it be a culture versus molecular. And I think with any infection control program, there's not really any true case control studies to really show, okay, specifically a particular infection control measure is the sole cause or reason why success was seen on the other end. So infection control, it's typically a bundled approach. You have various facets trying to work together towards a common goal or program. So again, it's hard to really have a true case controlled study. And I just put one reference here from the Journal of Clinical Microbiology to screen or not to screen for MRSA. And it's a particularly good article with sort of a point-counterpoint. One of the authors is from an institution, obviously, that has a MRSA screening program in place and has implemented and shown success. And then others, the other institutions, again, they have not implemented MRSA screening, and they give very compelling reasons on both ends. So to get into our specific environment in our planning and implementation, and I show here kind of a timeline, and we really started planning and developing this back in November 2007. I had attended a conference, one of our infection control practitioners had attended a different conference, and we came back and we shared notes, and actually that's kind of where this whole inception of MRSA screening in our institution was sort of born. We thought it was a worthwhile effort, and so we started that initiative and getting firstly administrative support and kind of infectious disease infection control support to say, okay, yeah, this is going to be beneficial, or we think this is going to be beneficial, versus no, it's not. So with something like this, it really requires a top-down effort from the administration, and then it sort of trickles down to the clinical staff, nursing staff. I mean, from A to Z, it really affects the whole institution. And so I highlight here some of the bullet points that were important in sort of getting the planning and development going. And really, when you look at forming the multidisciplinary teams, it's really important to involve all the stakeholders. And this is something that we probably took a lot of time, probably the bulk of the planning and development, and just coordinating the efforts between the different disciplines, obviously laboratory infection control, but medical staff, nursing staff, administration. And of course, one of the difficulties we came across was just with the infectious disease clinicians for the system, for our healthcare system. They obviously saw the benefit, and they were on board with us, but they're busy clinicians. They're still seeing patients. They're doing consults. And so they were there, they were with us in spirit, but it was hard to really get the effort out of them to really spread the word to at least clinician to clinician interaction. So it really eventually became a laboratory infection control kind of spearheaded effort towards getting this program off the ground. And I mentioned obviously administration here being important. Pharmacy was important because we are in our educational efforts were that if a MRSA patient or a patient were MRSA colonized, then they would undergo decolonization regimen, and so that was key to get them on board, obviously for the Bactroban and chlorhexidine decolonization. One of the educational, at least a couple of educational efforts we did was bring in speakers from institutions that have already implemented MRSA screening. So it's always good for our clinicians, our administrative staff, to hear from other outside institutions that they've went through this process, that they've actually had success with the process. And so it was good to hear outside of us, the laboratory infection control, telling administration and medical staff to hear this outside person, non-healthcare system person, tell their story, tell their successes, tell their challenges, so that we could best adapt a MRSA screening program to fit our institution. And then it goes without saying with the patient bed control, obviously, there, at our flagship hospital, it's a semi-private room facility, and so the placement of patients needs to be orchestrated carefully, just because infection control did not want to cohort a MRSA colonized patient with a non-MRSA colonized patient. So there was that required a certain amount of effort there. Thankfully, our other institutions are all private rooms, so they really didn't have that issue to deal with as we do here at our flagship hospital. IT is key here just because in the laboratory we're in the business of information delivery, and so it's important to get results out in a timely manner, and so that infection control, medical staff, nursing staff is aware and can take the appropriate measures. And that would be contact precautions and then starting the decolonization regimen. Initially in the planning development, our infection control and medical staff wanted the laboratory to call on all our positives to the floors, essentially treating it as a critical value, which we felt our staff is not would not be the best use of their time. I mean, we need our medical technologists to be medical technologists, and at the time, the healthcare system had a few months before that had implemented Theradoc, and if you're not familiar with Theradoc, it's a relational database that marries microbiology laboratory data with pharmacy and with infection control. So, and the neat thing about the Theradoc is that the end users, infection control, nursing, even clinicians, can customize alerts so that infection control can set up, okay, when a MRSA screening result comes back positive, I want to be alerted, and that's either by email or it can be done by a page. So at least they're automatically alerted, and that sort of eliminates the requirement by the technologist. And really, it's done in a more timely manner than it could be done by a person trying to find someone. So that's good. And so now what we have is important to have that Theradoc implementation in place. So we definitely took advantage of that. So next, as they say, a picture is worth 1,000 words. And so what we presented to our administration is that, okay, because we don't have a MRSA program in place, this is what we're capturing as far as patients with a clinical MRSA infection. Now, knowing what MRSA colonization, the implications with that, we presented to our administration and said, hey, we're only getting the tip of the iceberg. What about all those patients that are just MRSA colonized and not overtly have a clinical infection? So this was kind of the idea of identifying these patients so that they can so that appropriate precautions can be implemented, decolonization, and they don't serve as reservoirs of infection within our healthcare institution. And there was a study in clinical infectious diseases in 2004 that stated that about 30% of those that are colonized with MRSA that are hospitalized actually end up with an infection with their own colonizing MRSA strain. So again, the implication is preventing and identifying reservoirs of MRSA colonization, and then was preventing MRSA infection in these patients that are MRSA colonized. So to get into kind of our strategy for MRSA screening, what we have, there's kind of two schools of thought. You can go the universal route and screen everyone that comes in and gets admitted to your healthcare institution. You can also selectively target high-risk patient screening, and we didn't know which way to go. Logistically, and probably for the sake of the laboratory staff, we kind of wanted to avoid the universal screening just because we'd be testing everyone, but we really needed to know which way to go, and so that's where point prevalence studies came in. And so what we did was a one-day snapshot within our healthcare institution. We looked and took an anterior and air swab of all of our inpatients as long as they consented, and we had almost 99% consent. So we got a good representation of the inpatients in our healthcare system, and we found that 9% of our inpatients are MRSA colonized. And when we drilled down and looked at those MRSA colonized patients, we found that all of those fit in our high-risk category. And so just to define what our high-risk category is, we took a mix of what we've seen at other healthcare institutions that have already implemented a MRSA screening program, and then we took some of what APIC considers high-risk patients. So we came up with this list. And so as you can see, critical care admissions and transfers, so whether they're admitted directly to the ICU or they may be on the general floor, and if they haven't been screened yet, they're going to be screened before they, as they enter the ICU wards. Admissions from long-term care facilities, patients who have previously tested MRSA positive, and that's colonization or had a documented MRSA infection. Dialysis patients and chronic renal failure patients, admissions with skin and soft tissue infections, and then just those frequent flyers that seem to be showing up with increased frequency to our healthcare institutions. Additionally, we also implemented MRSA screening as part of a pre-surgical workup. When patients come in, usually 5 to 7 days before their procedure is scheduled, along with the normal routine blood work, lab work, they will get an anterior and air swab and get tested for MRSA colonization. And again, if positive, it's communicated back to them, and the script is given to them to go to the pharmacy to get the decolonization regimen of a chlorhexidine and Bactroban. And so by the time they show up to or for their procedure, they should be decolonized and at least protected for that time during the procedure. So getting into at least the, when you talk about molecular screening or MRSA screening, we did evaluate molecular versus a chromogar, which is it's culture media, but if it's MRSA, then it shows up a particular color. So it's somewhat eliminates some of the post-testing that you need to do to confirm. Although, as I'm sure many of you know, the chromogars aren't completely 100% specific, and there's some issues and false positives. So I think one of the big limitations for us of why we did not go with culture is just because of the time issue of getting results out. 18 to 24 hours at least for culture. While with a screening test, right now we're getting results out in about 11, 12 hours. Actually, excuse me, 12 to 14 hours. So I'll talk more about our turnaround time later on. And I mentioned the decolonization regimen, and here is the specific one that we use. We actually got from another healthcare institution. So it's with the Bactroman ointment in the nares 2 times daily, and then chlorhexidine bath or wipe downs, depending on how ambulatory the patient may be. And so the total decolonization regimen is about 7 days. And then just revisiting the timeline, so again, the timeline for the planning development beginning in November 2007, and then we actually went live October 2008. One of the difficulties with going live in October, in parallel, our molecular lab was actually moving to a different laboratory just for sake of space. It was bigger space. And so we actually ended up moving September 2008 into our laboratory, new laboratory at the time. And so we had about a month to really get everything set up, validated, and ready to go. And thankfully, with IT and our lab staff, we were able to go live. And it was actually mid-October 2008. We decided to go hospital by hospital versus a big bang approach. As I mentioned earlier in the introduction slides, you saw how big our healthcare institution is. And we felt going live with a smaller hospital, we could work out the kinks and operational things and it's impossible to anticipate all those things in the pre-go live stage. And so it was good to at least start small, get our feet wet, so to speak, work out the kinks, and then expand. And then you can see the timeline of when we went live with the various hospitals, and ultimately going live May 2009. So it took a good 6 months, 7 months to go live with the entire healthcare system on board. So just very lastly, to get into some of the MRSA screening outcomes and metrics, again, it's good for our administration and good for us to show that we're having a positive benefit on the patient side of things. And so here's some of the data, and I have here 16-17 hour turnaround time, and that was actually early this year before we had 3 shifts. And now with the 3 shifts, we're able to get results out in about 12-14 hours. And so that's from time to collection to time to result. And we usually have 2 runs per day. So we have a run starting around midday, and then usually run on our 3rd shift. So again, we're able to at least get a turnaround time that's satisfactory for our infection control practitioners. Again, with Theradoc, they automatically get alerted, so it really takes that time if we were to call all those positive results. And then I mentioned the pre-surgical screening is usually about 5 to 7 days prior to a scheduled procedure, so we definitely get those results out in a timely manner so that the clinician can implement the appropriate decolonization protocol. And then here's looking at our at least experience from the laboratory. So in the orange bars represent our MRSA screening volumes that we've seen throughout the years through the end of 2014. And then the blue bars represent the positivity rate. So you can see here with the volumes increasing throughout the years here, and we've noticed, I mean, in general, increased patient population showing up at our healthcare institution. So as time has gone on, we've had more patients coming in, and that's really led to our increase in volumes. Again, the positivity rate you can see here, and excuse me, the next slide I actually had positivity rate. So this is sort of capturing the latter half of in 2008 and 2009, so that's sort of combined here in that first column. And you can see with our MRSA rate sort of declining over time, and it's remained steady around the 14-15%. So this is what we're seeing. It's hard to say what this means as far as our efforts in identifying these MRSA patients and decolonization, but at least it's sort of an interesting observation to show a decline in MRSA colonization. Of course, one of the big things that our finance people wanted to see was, what's what's this costing the healthcare system? And I should mention ahead of time that the patient is not charged for any of this testing. So the healthcare system felt this was a patient safety initiative, something that the healthcare system is willing to eat the cost for. And we actually, part of our education to the patient is also we prepared pamphlets for the patient and patient families, where it explains what we're doing, why we're doing it, and so that they know that this is something that the healthcare system is ultimately covering for, at least for the MRSA screening. So in the yellow bars is the lab testing, and that obviously is going to be the majority cost just because of the testing, the reagents, and so this is really only considering the test reagents. Tech time is not included. Obviously, our techs are doing other assays, so it's hard to, would have been hard to at least break out that time. So this is really just looking at reagents. The blue bars represent the pharmacy cost, so the cost of the decolonization regimen. And then the green line here I have as the total cost, so lab plus pharmacy. And you can see, as you expect with volumes increasing, the cost of the program has increased with regards to lab and pharmacy. I did not include infection control, the personal protective equipment required for contact precautions, just because these patients, sometimes there's another reason why they are under contact precautions, and it may not necessarily be for MRSA in the beginning, so it's hard to account for that. And also, there's multiple times that healthcare workers go into a patient's room and they put on and take off these personal protective equipment. So I did not include that, at least to make it relatively easy to come up with a kind of a guesstimated kind of laboratory pharmacy cost. And so the next slide here showing in the blue line showing the decline in the number of MRSA hospital-acquired infections. So remember 2008, we weren't completely live, really live only in the latter quarter of the year. So we had a documented 184 MRSA hospital-acquired infections. As you can see over time, going to 2014, we had 29 hospital-acquired infections. And so again, showing a decline in MRSA hospital-acquired infections, but then also we wanted to put a dollar figure in this. So our infection control worked with our finance people to come up with, okay, what's it cost the healthcare system to care for a MRSA HAI, or hospital-acquired infection. So they came up with about $10,000 per infection. And if you look in the literature, we think this is a low, this 9,000 number is a relatively low number. We've seen, or I've seen numbers as high as 27,000, 35,000 as the excess cost of a healthcare institution provides for caring for a MRSA patient that had a MRSA HAI. So, but regardless, here's the numbers that were calculated. So basically 184 MRSA HAIs multiplied by 9,449. You can't, that's how I came up with these numbers here. And you can see over time, again, less and less expense for MRSA HAIs. And so this was something that our upper administration and our finance people saw a benefit. Now, one of the things in trying to, as concepts for our finance people to get used to was the cost avoidance. So what are we avoiding spending? And it was hard for them to sort of grasp this concept just because it's not a specific line item in a budget. It's something that we didn't spend. So one of the big assumptions here, if you look for 2008 here, again, this blue bars represent the cost that the healthcare system is spending to care for MRSA HAI. And the assumption here is that if we did not have a MRSA screening program in 2009 through 2014, that I made the assumption that, okay, we would have 184 MRSA HAIs across the board. So again, that's a big assumption. But if we didn't have a MRSA screening program, again, looking at the cost avoidance in the orange bars. So again, this is what we avoided, potentially avoided spending for a MRSA HAI. And so again, going from 415,000 in 2009 all the way to at least estimated for 2014, a cost avoidance of $1.4 million. So again, gave administration and finance sort of an idea of what we avoided spending. Again, talking with your finance people, it's good to keep that communication open, because obviously they speak a different language than the lab, and it's always good to like meet with them and show that we're trying to kind of explain the concepts, and not only, you know, it's a two-way street. So it was good to at least have those discussions with them. But again, they're starting to get the idea of cost avoidance, because we've used that term in other laboratory tests that we brought in. So again, good to establish that relationship with your finance folks. So I apologize, dealing with some technical difficulties. So in this slide here, where I put together the cost of what we were spending, you know, down here in 2008, 2009, as far as the blue bars. Again, the orange bars up here up top represent the cost avoidance that we estimated, and in gray here is where I put the cost of the program of the pharmacy and laboratory. So you can see, perhaps in the beginning we were spending 1.3 million. 1.3 million plus the 343,000, again exceeding the cost avoidance. But as time goes on, you can see here with 518,000 plus the 274,000, again probably closer to 800,000. Again, cost avoiding here $1.4 million. So it gives us an idea of where we stand as from a financial perspective. Again, not a true cost analysis, but at least gives us an idea of kind of the benefit we saw on the decline of MRSA HAIs, and then from a financial perspective as well. So to summarize all those kind of charts I showed, we saw an 84% decline in MRSA HAIs from 2008 to 2014. Again, adding up those orange bars in the cost avoidance assumptions, $6.5 million that we cost avoided. And so again, an estimation there, but gives administration something tangible to kind of hold on to and identify with, and something that we feel that our administration is proud of, to implement a patient safety initiative. Being a public healthcare institution, you know, everything we do is sort of we feel like we're in a fishbowl and everyone can see what we do. So it's good to show some benefits to bringing in and spending the money on testing and expenses for a MRSA screening program to show the benefits on the other end. So I just want to close out that, you know, with MRSA screening and really any infection control initiative, it's a multidisciplinary effort. Not only considering the pre-analytical steps and from collecting the sample, identifying the patient, performing the test, getting the positive result alert out, but then it starts a trigger or a sort of a downstream effect of, okay, the clinicians identified or notified that, you know, the patient is MRSA colonized, infection control gets involved, pharmacy, nursing, and then ultimately patient discharge, environmental services. So you can see where there's a downstream effect, and it's really a multidisciplinary effort to get the MRSA screening program off the ground here. And you know, I've heard the statistic where laboratory testing in general is about 3% of the healthcare dollar, yet clinicians and other medical decisions, 70% of those decisions are based off of laboratory data. So the laboratory is certainly a key part, but we need all the pieces working together in order to show any kind of success. So thank you for joining me, and I will now take any questions. Thank you. Okay, so we have some questions coming in the QA box. I'll just kind of read these. It says here, after this first question, after the 7-day regimen of treatment for MRSA, do you keep your patients in isolation? So yes, we do, just because they've been identified, and typically our patients, our average length of stay is maybe 4 or 5 days. So typically they're released, and once they're discharged, they're told to maintain and complete the regimen. Of course, once they're outside the system, it's hard to police that, but at least we do try and keep them in isolation. Usually, if they're going to be in longer than 7 days, there's usually something, some other underlying disease or reason why they're still in-house. So again, we just sort of keep that isolation going. The second question I see that's coming across, what MRSA molecular test methods have you used or are using? So we did start out with a lab-developed test back in 2008. So it was a test that identified Staph aureus from the other coagulase negative staph. So it was a molecular method. And then any Staph aureus that was identified, we actually ran those samples, or they were reflexed to the Gene Expert MRSA assay. And so this was in 2008. And we actually were running that for a while. And then and the ASR, or lab developed test, excuse me, was developed on the Roche Light Cycler. We then migrated over to the Roche MRSA Advanced as they got their MRSA assay FDA approved. So we were running that for a while. Again, with the volumes, there was a front-end step and processing step that required a lot of manual steps. Well, I wouldn't say a lot of manual steps, but it was manually done by the techs, where they had to break off the swab into a sort of a lysis buffer tube, and then preparation of PCR master mix. And so with our volumes, it got to be a little bit burdensome for our techs, and so we actually then did migrate over to the BD-Max, which is what we're currently using. And the good thing is the BD-Max is semi-automated, so you load the reagents, you load the patient samples. There you do have to break off the swab into a MRSA tube that goes onto the instrument. Once you load the instrument with the reagents and the samples, it does the extractions, it does as well as the PCR, and then gives you the amplification, or it gives you the final results. So at least you have it allows less hands-on time by our techs, so they can do other more critical things. And there are a number of other MRSA assays out there that may benefit you. And I mentioned earlier we didn't evaluate the chromograph, again, with the time issue of waiting that 18 to 24 hours. We felt that the turnaround time with a molecular method would serve our clinicians' infection control better. So next question, do we need to make it mandatory for every patient to be screened for MRSA colonization before major surgeries? Well, it's up to the healthcare institution. It's to really determine if MRSA is a huge problem in your institution and you're seeing perhaps a high rate of surgical site infections before your surgeries. I think that's something you'll have to address internally to really see, okay, if we implement something and we prevent MRSA's infections, could this be a means of doing that by implementing a MRSA screening program? So it's hard to say without knowing the sort of nitty-gritty details about your particular institution. So it's something you'll have to look at and address. Next question is, do you check Staph aureus, methicillin sensitive coag-negative staph, and methicillin resistant coag-negative staph? And so right now, no, we do not. That's something that we've been looking at, and actually, so again, I don't think currently, at least in the US, there's no, to my knowledge, FDA-approved assays that do separate coag-negative staph, methicillin-resistant, methicillin-sensitive. There are assays that will separate methicillin-resistant Staph aureus from methicillin-sensitive Staph aureus, and so we're initially kind of looking at that product, just because Staph aureus, whether it's MRSA or MSSA, methicillin sensitive, can be significant in a patient as well. So we're kind of looking at that route. We haven't moved to that assay yet. So again, something that we're looking at. Question comes with what's the current lab reagent cost for BD Max MRSA? I don't have those specific cost numbers. The cost numbers that I showed incorporated those 3 assays I mentioned that we migrated to and from. So I will have my email address available afterwards, so perhaps we can talk more offline and, about the general numbers with that. Let's see, this next question coming in. Did you differentiate the hospital-acquired MRSA from the patients who had MRSA prior to their hospital visit? And I can't see the rest of the question, and how I'll repeat the question. So did you differentiate the hospital-acquired MRSA from the patients who had MRSA prior to the hospital visit, and how was this done? So no, we did not differentiate the hospital-acquired MRSA, and I guess I'm maybe a little confused as to what in reference. Does that mean the patients that were coming in and then we identified them? Our infection control tracks the HAIs, or hospital-acquired infections, so hospital-acquired MRSAs. So they follow those numbers. I'm sure they have the MRSA infections that came in from the community that were not considered an HAI, so they have those numbers. So that was really an infection control question that I could certainly find out the answers for them. Again, I think my contact information would be available so that you can just contact me offline and I can try to find the answers to your question. The next question is, any experimental studies on the phage therapy for MRSA? And I have not seen any, and that's an interesting concept. Again, not having specifically looked in detail to any kind of therapeutic use of bacteriophages for MRSA, but certainly an interesting question. Apologize, I don't have a good answer for that. And then lastly, or at least this last question I have is, can a vaccine be developed to prevent MRSA? I guess you can develop a vaccine to almost any pathogen. I guess the question is, how do you deal with the normal flora? Because individuals can be colonized with MRSA and not come down with a clinical infection. They just are colonized. And there's actually, there's an article that I don't have the immediate references on in my head, but I know they do talk about patients can be intermittent colonizers, they can be persistent colonizers, and then some patients actually are seemingly resistant to MRSA colonization. So there's an interesting microcosm of looking at the host factors and how people can be those 3 categories of persistent, intermittent, or sort of resistant to colonization. It'd be hard for a vaccine to target that just because it can be normal flora and sort of survives happily, and it's sort of along for the ride and within host patients. So again, it's hard to say for sure how effective a vaccine would be. But again, I haven't looked at those in detail about that. Next question I have, what would be on your most wanted improvement list for current MRSA molecular test methods? Perhaps this could be taken offline. It seems to be a more detailed question. But I guess, one of the things with MRSA PCR testing in general is just trying to take account of all the MRSA types there are. As we know, there's the MEC-A, which is the genetic element responsible for methicillin resistance, and there's different MEC elements, and one of the advantages we saw with the BD Max is that it can detect MEC-C, which currently in the U.S. is not a very high prevalence, but at least It's been reported in Europe, and now with the world becoming smaller because of air travel and being able to go from one place to another within a day, it's certainly bound to show up in the U.S. sometime. So again, I think vendors need to be aware of all the different MEC types out there and different elements for MRSA, genetic elements, and just be aware of that, because any genetic elements or mutations observed can adversely affect the performance of the assays, just because primers and probes are developed to be specific for a certain gene sequence. If any of those genes or nucleotides are mutated, again, potentially leading to subpar performance or even resulting in a false negative. So again, something to be aware about. I see that there's no questions or further questions, so I guess I just want to thank the audience, and again, my contact information should be made available so that you know, if any other questions come up, or some of the questions that we better able to take offline, then I could help you answer those questions. Thank you everyone again for joining us today, and I turn it back to Judy.
I would like to thank Dr. Arcenas for his presentation. I would also like to thank our sponsor, Roche Diagnostics, for making it possible to bring this presentation